Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 43. This is the last of our mycoses, or fungal disease section. We're going to be talking about opportunistic mycoses. People you'll find with opportunistic infections either have AIDS, or they have undergone chemotherapy, or a bone marrow stem cell transplant, or they're diabetics. Knowing each of your at-risk populations will help you understand which agent is at use and which disease is most likely. We'll go through each of them in turn so you can be familiar with them and get the answers right on Step 1. Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 43, Opportunistic Mycoses. This table is going to be something you're going to want to commit to memory. It's an overview of the opportunistic mycoses, and these are infections found in the immunocompromised. These are good targets on USMLE Step 1 because they form distinctive diseases found in AIDS patients and other immunocompromised patients. You should be familiar with each agent, the disease it causes, where we get it from the environment, its symptoms, and its morphology. Candidiasis is frequently talked about. It comes from Candida albicans and others. We get it from endogenous spread from our own mucous membranes at normal flora, and it causes creamy growth on various parts of the body. Microscopically, you'll see budding yeast, septate hyphae, and pseudohyphae in tissue. It can also have germ tube formation in serum. Aspergillosis can cause an acute aspergilloma or allergic aspergillosis or aflatoxin, caused by Aspergillus fumigatus. It's ubiquitous in our dust. You find it in construction sites, and compost pits. It frequently has a fungus ball in tissue. It's allergic and invasive through tissue planes. Microscopically, it's a monomorphic filamentous fungus that's dichotomously branching at acute angles and are septate. It has asexual fruiting structure. Pneumocystis carinii causes pneumocystis pneumonia and interstitial pneumonia. We get a fever, a non-productive cough, shortness of breath. On microscopy, you'll see silver-stained cysts in tissues. It's an obligate extracellular parasite, and it does not have ergosterol. Mucormycoses are caused by Rhizopus, Absidia, or Mucor species. We get it from the soil, Saprophyticus, and you can get it with various symptoms. You'll often have a black eschar. It invades through tissues very well and is a frequent cause of death in diabetics and immunocompromised patients. These form aseptate broad filamentous fungi, which have right-angle branching and asexual fruiting structures in mycelium. Candidiasis is a common cause of diaper rash, vulvovaginitis, oral thrush, and pareichonia. It is a normal host flora. When we have oral thrush, we have creamy white exudates with a reddish base, and it doesn't scrape off. We treat it with swish and spit preps or nystatin. Vaginitis has predisposing factors which are a high vaginal pH, diabetes, and the frequent use of antibiotics. In AIDS and immunocompromised patients, you can get invasive candidiasis in your esophagus, and then you can get it disseminated to almost any organ. Patients will frequently present with dysphagia or odontophagia, and they'll have white plaques in their oropharynx. Systemic infection requires either amphotericin B or fluconazole. Question. A 27-year-old intravenous drug user presents with difficulty swallowing. Exam of the oropharynx reveals white plaques along the tongue and oral mucosa. A tongue scraping is most likely going to show. So this is a clinical picture of somebody who's probably a little bit immunocompromised. They're an intravenous drug user and they're at risk for getting candidiasis in their different parts of their body. If you've got a white plaque on something along your upper GI system, you should think of candidiasis in this situation. And so you're going to see budding yeast with pseudohyphae. Question. Following an automobile accident, a 23-year-old female was hospitalized and an indwelling urinary catheter was placed. She developed multiple urinary tract infections. An examination of her urine specimen showed budding yeast cells and pseudohyphae. The most likely responsible agent is. Anytime you hear the phrase budding yeasts and pseudohyphae, you should think about Candida. This patient wasn't immunocompromised, but the catheter allowed the normal vaginal flora to go up the catheter and to cause a urinary tract infection. The answer for this question is Candida. Next question. A 25-year-old homosexual male presents with dysphagia, malaise, weight loss, and extensive white oral lesions, most prominent on the lateral borders of the tongue. These lesions do not scrape off using a tongue blade. The most likely diagnosis? what you have here is an immunocompromised homosexual male, and they've got white puffy lesions on their tongue. You would think about oral hairy leukoplakia, except for they need to tell you a little bit more about the viral etiology. With this clinical presentation, the most common diagnosis is Candida. Next, we're going to talk about aspergillosis and mucormycosis. These are some pictures showing the acute branching hyphae and the budding yeasts. This is a clinical picture of somebody's eye which is in a lot of trouble. Mucormycosis can cause orbital and ocular infections and can be fatal in diabetics and immunocompromised people. Question. A 45-year-old diabetic lady developed a necrotic facial lesion, epistaxis, protrusion of the left eye, facial paralysis, and biopsy of her lesion showed aseptate broad filamentous fungi with right angle branching. The most likely diagnosis is, so for this situation we have somebody who's diabetic, and they have these black lesions, and it's bursting through the tissue, and it's making a path for her brain, and the pathology showed right angle branching of a broad filamentous fungi. That's mucormycosis, and these are the features you'll want to remember about it. The treatment for mucormycosis includes amphotericin B and surgical excision. These people can have debilitating disease, and if you're not aggressive at excising the tissue and getting it out, it will be invasive and they ultimately will die. Following a bone marrow transplant, a 32-year-old male presented with a cough, productive of sputum and high fever. The chest x-ray showed characteristic coin-shaped lesions of the lung. A sputum culture on Sabarod's auger grew out septate hyphae with acute angle branching. The most likely diagnosis is, so this is aspergillosis. When you have the acute angle, it looks like a broom head with the branching. That's going to be aspergillosis most likely more than anything else. Mucormycosis, you're going to look for your right angle branching. Histoplasmosis, you're going to look for a macrophage with lots of little histoplasma inside of it. In candidiasis, you're going to look for pseudohyphae. Next question. Aspergillus commonly exists in which of the following fungal forms? So this is a question of what you know about aspergillus, and the answer is it's a monomorphic mold. It only has one form, and it's always the mold form. It does not transition into a yeast. Question. A 28-year-old male patient is recovering from a bone marrow transplant. Which of the following infections with Aspergillosis fumigatus is he most likely to suffer from? So here we have somebody who's just had a bone marrow transplant. They've been irradiated and they have no immune system whatsoever. Normally, we're able to fight Aspergillus, and so it doesn't cause very much disease. But if you wipe the slate clean, you're going to get invasive aspergillosis, and you're going to get thrombosis and infarction, and this person's going to be in bad trouble. Cryptococcus neoformans is an encapsulated yeast, and that capsule is important diagnostically. We get it from soil enriched with pigeon droppings. Remember, with histoplasmosis, we worried about bird and bat droppings. With Cryptococcus, we worry about pigeon droppings specifically. It can cause meningitis, Hodgkin's lymphoma, AIDS, diabetes, or with no immunosuppression. You can also have acute pulmonary infection in people who are exposed to lots of the organism, such as pigeon breeders. If you want to diagnose the meningitis, you have to look at the CSF, and that's where you detect the capsular antigen with latex agglutination. The India ink mount is also important, and you can grow cultures where it will grow a urease-positive yeast. Unfortunately, we frequently diagnose it through autopsy, where we can use our Fontana-Mason stain and a mucicarmine stain. We treat cryptococcal meningitis with amphotericin B and fluconazole. This is a picture of the India ink mount, and you can see you've got an organism in there, and look at that capsule, that broad, clear zone, indicating the capsule. Question. A 26-year-old AIDS patient presents to his physician's office in Dallas, complaining of fever, headache, nausea, and vomiting. His past medical history is significant for PCP pneumonia and a total CD4 count of 70. The CSF reveals 8 white blood cells and budding encapsulated yeast grown on Sabarod's auger. Which of the following is true regarding the morphology of the infectious form of the organism responsible for the man's illness? So here we have somebody with cryptococcal meningitis. They're an AIDS patient, and they tell us everything about it, but they want to know what it would look like microscopically. And the answer is it's encapsulated. So you look for that capsule, which is answer D, and you've got an encapsulated budding yeast. Next question. A 33-year-old HIV-positive male complains of headache and blurred vision. Physical exam reveals papilledema and ataxia. CSF, obtained by lumbar puncture, reveals encapsulated organisms, observable with India ink. What's the treatment of choice for this infection? So we have a little bit better, or a little bit more in our clinical picture of what cryptococcal meningitis looks like. We've got papilledema, or swelling of the optic nerves. We've got ataxia, or nervous system dysfunction. And then we've got these encapsulated organisms on smear from CSF. We treat cryptococcal meningitis with amphotericin B. These last few slides are going to be clinical manifestations of fungal infections. It'll serve as a good list for you to review right before the test, just so you can be familiar with the different species. If you have diffuse interstitial markings on the chest x-ray in an HIV-positive patient who presents with shortness of breath, he's got a positive silver stain and he responds to Bactrim, you have pneumocystis carinii. If you've got thrush in a cancer patient receiving high-dose chemotherapy, you have Candida albicans. When you have an HIV patient with signs and symptoms of meningitis, with positive India ink stain on lumbar puncture, you're thinking about Cryptococcus neoformans. Somebody shows up from the Ohio River Valley and they've got lung granulomas and an intracellular yeast inside macrophages, you worry about Histoplasma capsulatum. Tinea curis, Tinea corporis, or Tinea pedis, you think of the dermatophytes, you think of trichophyton, epidermophyton, and microsporum. If you have somebody from the San Joaquin Valley in Southern California and you've got lung granulomas and spherules with endospores, you think of coccidiomycosis. Somebody shows up and they've got a fungus ball and a cavitary lung lesion that can be angioinvasive and cause thrombosis, Aspergillus fumigatus. Somebody with a systemic mycoses involving the lungs, bone, and skin, and they've got a broad-based budding yeast, blastomyces. You also want to ask about where they got it and exposure to rotting wood. If you have somebody with an ascending lymphangitis after getting pricked with a thorn, that's Sporothrix shechnii. And somebody with severe rhinocerebral infection and a diabetic ketoacidosis, you've got non-septate hyphae with wide 90-degree branching, then you've got mucormycosis. Wrapping up Module 43, we talked about opportunistic mycoses. Think about this in your patients who have AIDS. Also think about it in patients who have had transplants, who are immunocompromised for other reasons, and think about it in diabetics. In HIV-positive patients, you should think about aspergillosis, causing an infection in the lung. You should talk about pneumocystis carinii and be familiar with its presentation and chest x-ray finding, and also the treatment. You should be familiar with candidiasis and the myriad presentations it can have. You'll frequently find it, and by diagnosing it and by looking at the cells on slides, you'll be able to figure out what it is. Also in diabetics, don't forget to think about mucor. This can kill them and can be frequently found in diabetics with nasal infections that can travel through and get to the brain. Next up, we're going to talk about parasitology in Module 44.